Good day, class. Welcome to this Intro to Forensics class, lecture number 2. I am Professor Darrell Willett, the primary instructor for this course. A quick review of lecture 1 described how basically the history of crime scene investigation. In this, and also its components, the important components of crime scene investigation. In this lecture, I'd like to talk about the importance of evidence found in a crime scene and how that evidence can help us solve crime, how evidence can point to the guilty party, and also how that evidence can possibly prove innocence or exonerate individuals that have been falsely accused of a crime. I'd like to start off by talking about the Diane Downs homicide case. Now, this is a homicide case that occurred in 1993 in the state of Oregon. Diane Downs was accused of shooting her 3 young children. But the initial report of the crime indicates that Diane Downs is a complainant who is saying that an unknown person shot her 3 children. She drives down a highway late at night with her 3 children. She pulls her car off the shoulder, gets out and opens the trunk. Moments later, she peers through the driver's side window, gripping a .22 semi-automatic, and shoots all 3 children inside the car. She then gets back into the car, fires a shot into her own arm, and slowly drives to the hospital with a tale of being attacked on the road by a stranger. So police are called to this crime scene where the shooting occurred.
So last but not least, we're going to talk about drugs affecting the urinary system, specifically talking about fluid electrolyte balance. And obviously we already know that the kidneys play a key role in the homeostasis of fluid and electrolyte balance. We also know that fluids play a key role in the cardiovascular system, directly influencing circulating fluid volume, which plays a key role in determining as a determinant of blood pressure and cardiac output. And we also know that electrolytes play a key role in the cardiovascular system or the cardiac system, particularly when we talk about potassium. So our emphasis will be on there. And so we use fluid therapy for a number of reasons. And so this lecture is really going to just speak broadly to that and highlight some key points about fluid and electrolyte balance. So remember, when we talk about fluid balance and we talk about what total body water is composed of in the body, we talk about intracellular fluid, interstitial fluid, and plasma volume. And so know that 60% of the adult human body is water. And so when you think about its influence, we just talked about diuretic therapy. Obviously, that's playing a significant role in influencing the balance of that. And then when we talk about whether or not we need to use fluid IV therapy with fluids, administration of fluids, there are various types of fluids that either extract excess fluid from the system or reinfuse or instill fluid into the system. It just depends upon what the needs are for the individual. And so when we define intravascular volume, we're talking about fluid inside the cells. We're talking about extravascular fluid, fluid outside the blood cells like lymph and cerebrospinal fluid. Extravascular volume is seen as plasma, and then interstitial fluid, which is fluid in spaces between cells, tissues, and organs. And then extracellular volume is seen as interstitial fluid and intracellular fluid. So again, just the various components, just broad array. You don't need to know this. It's just kind of a preface to thinking about how the human body is composed of various sources of water or fluid. So when we use different infusions, we use them to influence the balance. So either we want to enhance the amount of fluid in the system, or we want to extract or remove or reduce the amount of fluid. It just depends on what the underlying issue is. And so when we refer to fluids, we refer to them as isotonic, hypertonic, or hypotonic based on that influence. So isotonic, essentially, we're maintaining balance. There's no net fluid change. We just want to maintain where we're at. So there's no need to increase or decrease, but we certainly want to maintain that balance. Hypertonic, because we actually want to expand plasma volume, and what we're doing is we're drawing fluid from the cells and the interstitial fluid to plasma volume, thinking about blood volume. And so obviously that has a significant influence as well in terms of its influence on the cardiac system or the cardiovascular system. And hypotonic, we're actually saying there's too much plasma volume and we need to remove some. So we move the water from the plasma and we shift it into the interstitial fluid or cells. And so again, that's how we describe the types of solutions that we're using and what their purpose or goal is in terms of therapy. So there are a number of parenteral or IV solutions that we can use, and so these comprise what we are primarily going to refer to, or what you're going to see in clinical practice. This is primarily acute care setting, right? They're in a hospital, they have an IV, there's a bag hanging, and what type of fluid is hanging determines on what the underlying need for treatment is. So blood products, obviously are replacing or supplement blood loss, so it could be plasma, platelets, packed red blood cells. Colloids are albumin or protein based. And then there's combination of treatment of carbohydrates, proteins, fats, nutrients, and electrolytes for nutritional supplementation. And so we can use that particularly for folks that are not able to take anything in orally and via the GI tract. And so, for example, a patient who has pancreatitis is likely not going to be able to eat orally for that reason. And so we need to supplement their needs somehow else. And then crystalloids are the ones that you're going to see most commonly used in practice. And so this is your classic saline that's used for folks in the acute care setting, and can also include dextrose. So crystalloids and colloids are the ones that are going to be used most readily. And so they're really designed to treat fluid depletion. They're really designed to replace what's lost. Could be lost from GI fluids because of sweating. Burns typically cause fluid shifts into the interstitial spaces, so they actually take it out of plasma and shift. This is essentially what happens often in shock. Hemorrhage secondary to blood loss, right? You have to expand plasma volume because you're losing blood from a source. And excessive diuresis, so again, I've lost excess fluid volume secondary to the renal effect. So how we define them is crystalloids typically contain electrolytes, so a sodium chloride, for example, is one we can see all the time, NaCl. And colloids, remember I told you an example of that is albumin, are proteins, albumin being the protein. They are helpful because proteins are larger molecules, and they actually remain in the bloodstream for a longer period of time. And so they do a better job in expanding the volume. That's why they're called volume expanders, because they're there for a long period of time. They help maintain that volume expansion, which is often needed in particularly acute type situations. So we mentioned a lot of these, but essentially it's when there's something that's causing low volume that needs to be replaced. Burns, as I mentioned, is often because fluid shifts into the interstitial places secondary to changes in that tissue and the capillary bed permeability. Essentially, shock is because you have a loss of circulating fluid volume that could be directly related to volume loss or blood loss. It could be neurogenic or cardiogenic as well, but there's something that's influencing that. Renal dialysis, because when a patient undergoes renal dialysis, I'm actually trying to remove excess fluid from the system. I'm supplementing the functioning of the kidneys, and if I lose too much fluid or remove too much fluid from the system, then obviously that was what I can see. And hypoproteinemia, low protein levels in general. Remember we said protein are larger molecules. They help sustain volume. When you have low protein levels, there's nothing to help sustain volume, and that volume shifts. Plasma volume shifts into interstitial spaces and it needs to be brought back into plasma volume to maintain adequate circulatory support or adequate cardiac output. So crystalloids are your most commonly used or administered types of solutions. Remember we said they're hydrating, isotonic, maintenance, or hypertonic. Again, just depends on what their purpose or what the need is for. Their volume expanding capacity is directly related to their sodium concentration. And so remember what we already know, that water follows sodium. And so that's how we're influencing fluid volume status. Commonly used can maintenance fluids, so depending upon that, dehydration when I need to draw fluid into the system, and obviously fluid electrolyte disturbances because I can supplement fluids and electrolytes within that solution and infuse in obviously into the circulating fluid volume to restore balance. Colloids, remember, move fluid from the interstitial spaces to the plasma by pulling fluid into the blood vessels, and this is directly correlated with protein. That's why when we said there's low protein levels, there's nothing to hold on to that fluid. It shifts into the interstitial spaces. So that's why we refer to them as plasma expanders. These are naturally occurring products. We actually are using, again, what we know about the body system and influence on fluid volume status to supplement, to mimic, to modulate that same effect. And so again, because they're larger molecules, remember I said they maintain plasma volume for a longer period of time. So that's why they tend to be more effective when we're looking at trying to expand plasma and maintain that level. So important nursing implications for colloid and crystalloid therapy. I'm typically adding fluids to the system, and so I'm thinking about raising blood pressure, and so obviously I need to monitor cardiovascular status. I need to know what vital signs are. Heart rate, blood pressure will all be important indicators or clues as to whether or not, number one, they're getting adequate fluid resuscitation, or if I'm giving them too much fluid. So for example, if I'm giving a patient who has too much fluid, they might exhibit signs and symptoms of heart failure because I have too much fluid on board. So I get signs of circulatory overload, meaning I get a high blood pressure. I have fluid that's shifted or moved into the lungs. So when I listen to lung sounds, I have evidence of pulmonary congestion. Again, a lot like a heart failure patient. Those are indicators or clues that I'm giving too much fluid. I monitor INO because whenever someone is getting any type of IV therapy, it's important to know what's going in and what's coming out to make sure that we're maintaining balance and that we're aware of that. Generally, there's no real signs of allergic reaction because these are fairly benign of sorts infusions. But on rare occasion, there's a sign of allergic reaction, so you just monitor patients closely for that at the onset of therapy. But again, a minimal risk there typically. So we said, remember, that the crystalloids, the influence on volume status is really directly related to the amount of sodium that's present in the concentration. And so we say, right, sodium chloride in crystalloids, or NaCl, you'll see. So normal saline is what this is referred to, or 0.9% sodium chloride is the most common concentration you're going to see in clinical practice. What bag is being hung, for example, in the patient room. 0.45% obviously is half of normal, 0.25% is quarter of normal. And if it's high in salt, 3 to 5%, that's your hypertonic solution. Again, so we talk about the correlation with how it influences volume, water balance based on the amount of sodium present in the saline, in the fluid. And then we said albumin, remember, is your protein-based larger molecules. This causes an increase in onychotic pressure of blood to cause fluid to move out of the tissues back into that general circulation to increase plasma volume. And so very helpful in shock-like situations because that's when I really need to restore fluid volume status, plasma volume to maintain adequate circulatory support. Immediate onset of action for that reason can have allergic reactions, but in general we're trying to use something that's very synthetic or similar to a naturally occurring substance. And obviously this is going to really increase plasma volume substantively, and so it's going to raise blood pressure, and in turn it's going to raise heart rate. It's going to make the heart work harder, and so patients who would be contraindicated would be somebody who has cardiac failure because they won't be able to tolerate that increase for sure. Dextran is another, dextran 40 or colloid. Obviously, this is another example of a plasma volume expander. Works very similarly as what we just described in albumin. and again does the same exact action. It's going to increase blood pressure because it's going to increase plasma volume significantly, thereby increasing cardiac output. Obviously, in patients who have a low cardiac output or low volume, this is going to help them. But when we increase the amount of plasma volume, it's going to directly influence blood pressure, thereby increasing blood pressure, and it's going to create the same potential risk as we talked about in albumin, the risk for cardiac overload or signs of fluid overload, rapid heart rate, edema because fluid shifting, distended neck veins or JVD, and dyspnea or cough showing pulmonary congestion or extension or kind of a movement of fluid into the pulmonary bed. If they're going to react, urticaria, kind of itching hives is the most common reaction that you might see. It doesn't mean that it's going to be contraindicated for its use, but again, not significant in terms of the amount of allergic reactions we see, but certainly if it's the first time a patient is ever getting anything in drug therapy or other any type of therapy, one of your priorities is always going to be to assess for allergic reaction. So nursing implications if you're going to use fluid therapy or IV therapy, obviously you want to know what their baselines are. How is kidney or renal functioning going? Because if I give more fluid and I don't have good renal function, we're going to have a problem with excretion, right? If they have a hematocrit below 30%, that's an indicator of clue that they probably are experiencing blood loss or they're bleeding from somewhere or likely hemorrhaging. And they need obviously some additional intervention because we need to find the source of the bleed and stop the bleed. Renal failure, we know it'll be contraindicated because they can't, obviously renal function is going to be impaired and they're not going to be able to excrete accordingly. Hypervolemic, meaning I already have excess fluid volume, why would I want to add more volume to the system? Severe heart failure, because remember, your heart can't pump as it is, and so when I add more fluid volume to the circulatory system, it's going to overwhelm the heart. Clotting abnormalities, thrombocytopenia, again, risks for blood clot development, particularly there. And again, vital sign monitoring is going to be important because that's going to tell you how they're responding to the increase in fluid in the plasma. How are they responding to the increased plasma volume? What are their vital signs doing? Are they tolerating it well? Is it achieving its intended or desired effect? And again, certainly, as I said, the first time you're giving something, you always observe for hypersensitivity reactions, allergic type reactions. So hives, itching, something more severe would warrant, again, concern in terms of if it's impacting breathing. If you're seeing swelling around the face and lips, would obviously be very concerning in terms of a more anaphylactic type reaction. Some noteworthy fluid and electrolyte imbalances. I'm just highlighting a few here because we're talking primarily about IV fluids that contain sodium to influence fluid volume status, and we talked in the last lecture about diuretic therapy and its influence on potassium levels, and these are important or noteworthy in terms of their role. And so I've just highlighted here what are seen as high sodium levels, low sodium levels, high potassium levels, and low potassium levels, and what might you see in terms of systemic manifestations or signs and symptoms, clinical indicators or clues that they're experiencing this. And hypernatremia, obviously, I'm retaining excess sodium, and so with excess sodium, we're going to see a lot of fluid retained as well, and so that's going to influence, definitely see signs of edema. In low sodium levels, you actually see a lot of changes in cognitive status, lethargy, disorientation, and can lead to seizure and coma. In hypokalemia, it definitely influences muscle weakness, and the biggest concern with potassium is its influence on the cardiac cycle, so risk for dysrhythmias. And so I'd say potassium level is something you need to know. This becomes ingrained in your mind when you work in nursing for sure, and sodium levels as well. And so just keep these in mind when you're working with patients and looking at treatment options. Hypocalcemia here as well versus hypercalcemia and hypermagnesia and hypomagnesia. Again, looking at various levels, what do you see? In hypocalcemia, you'll see hyperactive reflexes. Again, calcium plays a key role in cardiac dysrhythmias and cardiac vascular symptoms, so those are noteworthy as well. And risk for seizures in low calcium levels, and hypermagnesia. Again, similar symptoms of hypercalcemia as well. And so again, just noteworthy in terms of the electrolyte imbalances that can present in clinical practice. So electrolyte supplements, obviously we already talked about sodium chloride or NaCl. That's typically used, right? We're using it as the IV fluid of choice. And so again, depending upon the percentage or the amount of sodium present in the fluid, the IV fluid will determine how it influences sodium levels. We've talked a lot about this really already when we talked about various solutions, but again, you're always worried about if you're giving a solution that has a lot of sodium or more sodium, then you know you're going to retain more fluid. Your biggest concern is always going to be for fluid volume overload, which we talked about. They'll present similarly like a heart failure patient. Your vital sign monitoring will be key there as well. Potassium is an important one. I always say this is a need to know as well. Potassium supplementation occurs frequently. We can actually give potassium supplementation as an oral. So I can take it as a pill, I can take it as a fluid, as a liquid, I should say, or I can use it and supplement it in the IV fluid that I choose to hang and administer to the patient to supplement the potassium level. Again, plays a key role in muscle contraction, transmission of nerve impulses, regulation of heart. That's why it's significant in terms of risk for cardiac dysrhythmias. We have to monitor that very closely. Potassium levels 3.5 to 5 is the norm. And remember, most folks can receive an adequate amount of potassium in their diet. These are some potassium-rich foods that we know. Of course, we talked about leafy greens. Everybody thinks bananas and oranges, of course, broccoli, a lot of your greens we mentioned already. And so patients should just be, if they're taking medications that influence potassium levels, meaning they deplete, we want them to know what are potassium-rich sources in their diet. We also are going to monitor their lab values for sure to make sure that they're not experiencing low potassium levels that require additional supplementation. If we're going to supplement potassium, the things I want to mention is potassium chloride can be given via PO or IV. Noteworthy here is you never give an IV dose of potassium fast. It has to be given very slow. It actually can cause cardiac arrest. It's significant. If you're giving it orally via a pill, keep in mind most of the pills that they have out there, they're pretty large and sizable, cannot be crushed or cannot be chewed because they are designed to release potassium slowly. And so that's a big no-no. I've seen that happen more than once in a clinical setting. If the patient cannot swallow the pill, they have an oral or a liquid agent. The problem with the liquid, as I'm sure you can appreciate, is it doesn't taste very well, and so sometimes it becomes challenging for compliance. But think about irritation with meals, with the use of oral agents, and so you can use it with meals or antacids. And again, patients would be contraindicated, obviously, if they have some condition that would elevate their potassium. Renal failure, acidosis, dehydration will concentrate potassium levels. Burns can cause high potassium levels, and remember, administration of a potassium-sparing diuretic alone. ACE inhibitors is another drug if you're using them in isolation or alone that actually cause hyperkalemia or cause are potassium sparing in general. So keep that in mind because you will see potassium supplementation used routinely, particularly with your cardiovascular patients who are on diuretic therapy, multi-diuretic therapy, because that's what they're using to control their disease. So remember, generally, if I'm giving potassium as a supplement, I need to know what their potassium levels are because number one, I want to make sure that they remain within therapeutic levels or within normal levels, 3.5 to 5. Obviously, I should withhold potassium if the potassium level exceeds the normal range. And again, I have to think about renal function. If they have impaired renal function, they're going to retain potassium, so they're going to have elevated potassium levels to begin with. Remember, potassium plays a key role in the cardiac conduction cycle, and so watch for life-threatening dysrhythmias. Patients should know signs and symptoms of hypo and hyperkalemia. I say, a lot of things with muscle spasms, weakness, muscle pain, and then sensations of abnormal irregularity in heartbeat, heart rate, senses of flutter. Those are all indicators or clues that they could have an abnormality or an imbalance in their potassium levels. And if they're taking actually a potassium supplement, so I'm giving them an oral dose of a potassium supplement, then I don't want them to go crazy in their diet and have a lot of additional sources of potassium, because I want them to maintain within that therapeutic window. And just keep in mind that the patients, particularly who are taking potassium supplements, are often your heart failure patients that are already on a salt restriction, and your salt substitutes that are marketed actually contain a ton of potassium. And so if they're using those and taking potassium supplementation, they could be at risk for hyperkalemia. And so while they think they're doing something good by avoiding salt, those salt substitutes are really replacing potassium for the salt. So to conclude, just think about key nursing considerations in fluid and electrolyte balance, right? If you're going to be administering fluids or electrolytes, you want to know what baseline fluid volume and electrolyte status is. What are you supplementing? What are the overarching goals of treatment? Where are they at? Remember, baseline vitals will be key, because you're going to use the vital sign monitoring throughout therapy to determine their response to treatment and whether or not response is appropriate, and that we're not administering too much fluid or too much electrolyte. Skin and mucous membranes obviously are good indicators or clues of hydration status. Daily weights are good indicators or clues of whether or not fluid volume status is maintained and balanced. And remember, I said anytime you're giving an IV fluid, some type of fluid via IV, a strict INO is key. You want to know what's going in and what's coming out, again, to help determine balance and overall homeostasis. If you're giving potassium, particularly via IV, you definitely want them on a cardiac monitor, and you want to assess their response. Remember, the risk is for cardiac dysrhythmias in response to potassium therapy. And obviously, you're going to monitor electrolyte levels to see how they're responding. You want to make sure that you're giving the infusion rate at this determined rate, or the ordered rate. Too fast or too slow obviously can impact functioning. You're going to note that obviously in their vital signs and response. You want to look at the appearance of the fluid or solution. If the fluid appears cloudy, it could indicate that it's contaminated and might not be important. You want to monitor the infusion site. They have a peripheral or essentially inserted site. You want to make sure that that remains patent and intact. And so indicators or clues would be if there's evidence that the alarm is sounding to indicate there's an occlusion. If there's areas of redness or swelling around that site, those could be indicators that that site's no longer patent, that it's infiltrating, and that would be concerning as well, and warrant looking at an additional site for administration of those